witness the whole event today, you can go back to the SEM surgery masterclass, module 13, you put in the YouTube. You'll be able to revise whatever we have discussed today, even today evening or sometime the next few weeks, so that you can take down some important notes on these two important topics. Because I repeatedly say to you, my approach is slightly different from the textbook approach. We go by seeing the patient as if they are sitting or lying in front of you with a problem. And also template-based approach. We always follow a system wherein we take a history, examine, investigate, treat, then we see the outcome. So that's the template-based approach. For everything, you have the same approach. And like a surgeon, there are key words in each chapter. Like, for example, any acute abdomen, there is bound to be a lot of signs. Okay, those signs you need to know how to elicit and understand the limitation of each and every sign. Okay, so with that, let's move on to the art of approaching the acute abdomen. Okay. Because if you are seeing a patient, for example, at 2 a.m., imagine you are now a qualified doctor, CRRI, posted in an emergency. You are seeing a 5-year-old boy brought by a mother, or a 15-year-old school-going boy coming with his uncle with a severe upper abdominal pain or a lower abdominal pain, whatever may be the pain. It is you on your own, probably with a staff nurse, have to get a history, examine, come to an working diagnosis, then take a phone, talk to me or somebody like me. Sir, this patient came, this is the finding. Then you may have to decide about the further treatment, because the timing is such that you may not be able to get either the bacterial, the biochemical or the imaging done for those patients at that odd time of the hours. So it is very, very important that we need to use all our expertise in good history taking and examination and a background knowledge of surgery in order to come to a conclusion without the luxury of all the imaging modality or any investigation, because that might be only done in the following subsequent day morning. So this is actually a test for your clinical judgment, and I would say probably an instinct, because if I see a patient after 30 years of an experience as a surgeon, it may take just a couple of minutes to come to a conclusion. Oh, this is a patient, acute appendicitis, he ought to have surgery. Or this is a patient of simple urinary colic, he can wait and watch. Like that, I am able to make a decision which might take even 30 minutes or longer for you as a young doctor. The difference is because of the experience and expertise. So that's that travel I want you to take. And let us go slowly into this very important chapter, as I say. You have a 5-step approach for any patient presenting with acute abdominal problem lying in the emergency room bed. First, go to the patient, and you have to imagine, you need to be very compassionate, because patient is in pain. So you have to be very, very swift in taking the history, then make the patient comfortable by giving some immediate analgesics, then start examining the patient, like inspection, palpation, percussion, auscultation. Then you decide about doing some basic investigation like urine, blood investigations, simple plain X-ray of the abdomen. These are all the things you can do. In bigger teaching hospitals, you may be having the luxury of a sonologist even available out of hours. So he may be able to help you to do any further investigation. Then your job till morning may be either prepare him for surgery or optimize. What I mean by optimize, give him IV fluids, analgesia, antibiotics, all those things. Then the next day morning, or if necessary, the postgraduate might come and examine the patient and plan for a definitive care. So this is the way we see each and every acute abdominal problem we see in our outpatient department or in the emergency room. So rightly said by William Kelsey, God gave us all ears, eyes. So you need to inspect. Before you inspect and palpate, you have to hear what patient is saying. So that's the way you have to look at this problem. So let's go on to the first important thing, listening to the patient carefully. So I'm sure all of you should have a good practice of going by all these important questions when you ask anybody about the history of acute abdominal pain, the onset, duration, and progress. Because most of the pain that our patients say, sir, I had a very nice dinner, no problem with my family. I went to bed, no issue. 2 a.m. I woke up suddenly with this pain on my right loin, going to, right up to the groin. Then I went to the toilet. I was passing urine, which was very burning, and there are a few drops of what it looked like is blood-stained urine. So very typical history of loin to groin pain, urinary symptom of immediate and instantaneous onset, ureteric colic. Next patient. Sir, I went to bed. I was a little uncomfortable after taking a meal because I had some non-vegetarian cooked in the lunchtime and went and I didn't get a proper sleep. The pain was up high up in the upper abdomen and a colic in nature. And I had a little bit of antacid in the cupboard. I took some, then I felt a little better. But again, I got up in the middle of the night, like 1 a.m. and I vomited a few times, but still I have a little uncomfortable burning sensation in the upper abdomen. So it is a very, very classical history of indigestion or gastritis. Third patient. Sir, I was upset because of some family issues. Yes, I admit I have been drinking a lot in the last 3-4 days. Yesterday I had 2 pints of beer and I went to bed today. I have little discomfort, but suddenly at 3 a.m. I had a severe pain. Now it looks as if somebody is stabbing me from front to back. I have more pain and I feel breathless and I haven't passed urine for the last 12 hours. And you look at the patient, patient is very, very sick looking. So it could be a case of acute alcoholic pancreatitis. So like that, if you listen to the patient's history without much interruption, but of course, direct him with these appropriate questions as and when required, you will get a storyline by the patient, which will clearly guide you to the diagnosis. In other words, the history is by far the most important thing. And in that one, the most important thing is the site of the pain and the character of the pain. I told you umpteen number of times the importance of the site of the pain. Say, for example, there are, as far as the abdomen is concerned, there are 2 types of pain. One is visceral pain and parietal pain. We discussed about the visceral pain already. I told you there are 3 important types of viscera. That is viscera from foregut, midgut, hindgut. The foregut is the GI tree, which is developed in the along the, it has a feeding vessel of celiac plexus. So whatever the organs developed from the foregut, starting from the esophagus, stomach, duodenum part 1 and part 2, right up to the ampulla beta, that is the foregut. Midgut, from the ampulla beta, that is duodenum, the whole of the jejunum and ileum, appendix, right colon, and the right 1/3 of the transverse colon, that is a midgut. The artery of midgut is, yes, superior mesenteric artery. The third is a hindgut. The rest of the gut supplied by the inferior mesenteric artery. Say, for example, now anybody asks you how an appendicular pain is going to be, immediately your mind should think appendix is developed from midgut. Midgut pain is periumbilical. So the visceral pain of appendix is always periumbilical. So the patient with appendicitis invariably starts with the pain around the umbilicus. Sometimes patient may say a little upper abdomen, but most of them they'll say it is central abdominal pain. Then shifting to the right iliac fossa. In other words, appendicitis to start with, it will have the visceral type of pain. Then if there is a local parietal peritoneum overlying the right iliac fossa, if it gets inflamed, then patient will have a shifting pain to the right iliac fossa, giving rise to what I call a McBurney sign. So this is what the parietal pain is more localized at the site of inflammation, whereas visceral pain is more ill-defined and it is according to the dermatome supplied. I mean, in other words, it will usually around the periumbilical as far as the appendicitis is concerned. And coming to the severity, can you measure the pain? Is pain measurable? We can say very severe pains are moderately severe and mild pain. It is okay, but it is not good enough. So one of the best way to define the severity is by using a scale, what I call a visual analog scale or a score, something like this, okay, where you give a pictorial presentation to the patient and just explain to him actually what it means. Then patient may be able to touch one of these figures. Yes, doctor, this is probably one of the worst pain I had. Like if you are giving it to a 40-year-old lady, she'll say, yes, doctor, 10 years ago, I had labor pain during the birth of my first baby. This pain today, what I'm having today, is as bad as the one I had. So this is one of the worst pain. She'll put her hand towards like number 9 or 10 in the visual analog score. That is bringing tears in her eyes. Whereas the other patient will say, like peptic ulcer pain, like ulcer pain. Yes, doctor, it is painful, but it is not that bad. I can manage till morning. Like that, they'll come. Say that is moderate pain, is a typical ulcer pain, like a 4 or 5, they'll say. But if same peptic ulcer, if it goes for perforation, like perforated duodenal ulcer causing peritonitis, then the pain will become increasing intensity, even more towards the number 8, 9, or 10, the visual analog score. So like that, the score gives you an indication to some extent about the pathology and also the patient tolerance also, because sometimes even a mild pain will give rise to severe, exaggeration. The patient will be rolling about, but nothing. Some people's pain tolerance is so low. That is different. But overall, visual analog score gives you an indication about the pathology. And also, if a patient has a score of 8, 9, or 10, it is a serious problem. You need to address the pain before even you think about examining the patient, because patient will not let you examine. As simple as that. Okay. The next important thing is the radiation. Very important. How the patient, like pancreatitis, radiating right through the back. Appendicitis, shifting from the periumbilical region to the right iliac fossa. Acute cholecystitis, right upper quadrant pain, radiating to the inferior angle of the right scapula. Cardiac pain, myocardial pain, from the left chest, radiating to the left shoulder and the inner aspect of the left upper arm or even the elbow region. So like that, the radiation gives you an idea what are we dealing with. Okay. Aggravating and relieving factors, very important thing, because something aggravates like gastritis or duodenitis, all related to the food habits. So sometimes eating spicy food may be the culprit, taking an antacid may be relieving, or vomiting might have relieved a patient. So like that, various relieving factors also there. Next important thing is associated symptoms, because most of these are like parasympathetic system. So they don't just come along with the, apart from the pain, they have additional symptoms. If you have a severe pain, now what do you feel? You feel like vomiting, like nausea, or actual vomiting, few episodes of vomiting. Or usually you have, if it is a cystitis, you have a urinary symptoms, or if you have like a colitis, you will have associated diarrhea. And also a fever is a very, very important sign of any inflammatory pathology, like appendicitis, cholecystitis. It may not be high-grade fever, maybe a low-grade fever is a very classical of appendicitis. Never fever, usually around 38, never above 39 in the case of acute appendicitis. Okay, so that's all about the symptoms. So once you've taken all those things, so what do you do? This picture I already shown you several times. Pain of abdominal pain due to foregut, like appendicitis, the peptic ulcer is here, appendicitis is here, cystitis is here. Okay, so they are all poorly localized, ill-defined, associated very often with this nausea, vomiting. Whereas if it is a parietal pain, they are usually on the dermatome pattern. You should know the dermatome pattern. D10 is umbilicus. Okay, above that, you know the dermatome, below that you should know. Because why this is important? Like for example, herpes zoster sometimes will present with just severe pain in the right upper quadrant. You think it is acute cholecystitis, but 2 days later, patient will develop single small blisters along the D8, T8 and T9, that dermatome, that side on the right side. Then it will reveal its diagnosis. Okay, but most of the time, the parietal pain characteristics are, they are precisely localized, exact point. Patient will say, sir, it hurts here, like that. They will be able to precisely locate. Intense pain, and it increases on movement, because any parietal pain or parietal peritoneum is, if it is touched, so patient will be lying still. Whenever you have peritonitis, one of the classical feature of peritonitis is patient lying still like a statue. He will be lying still. So that is all important for you. This picture is worth, after a few more months down the line, you go back and revisit the picture just to give you an idea of various types of referred pain. As a resident, you should understand. Okay, the typical one, for example, cardiac pain, for example, take it from me, how it radiates. If you have, for example, a patient with gallbladder pain, sometimes you can have pain over the shoulders also. Or if you have problem with the prostate or urinary bladder, not only you have a pain in the suprapubic region, but also sometimes in the gluteal region or perianal region. So like that, you will soon realize the pain, and also the pancreatic pain is more referred to the back. So this picture is very, very important, but to comprehend or to clearly understand, it needs you many years of experience. So just keep an eye on this picture, very useful at a later date for you all. So the challenge for you young doctors is to find out, if you have two patients with acute abdominal pain comes, which is a serious one, which is a less serious one, or which is a gastritis, which is an appendicitis. So that is a challenge you have. But you can get there if you follow this 5 important diagnostic basket, I call it. In other words, there are about 100 different causes for acute abdominal pain. But as a resident, all you need to know is, if you get a good history, examine, then you put the patient's diagnosis in one of these 5 baskets. Is it a case of shock or catastrophe type? Or is it a type where there is a hole in the bowel, that's why he's behaving like this? Or it is one of this inflammatory pathology of the bowel, like itis, everything finishing with itis, like cholecystitis, appendicitis, diverticulitis, colitis, cystitis, like that. Or is it something where there is a blockage in the bowel, traffic jam, like small bowel, large bowel, things like that? Or is it something medical, but coming into the wrong department? Like, for example, diabetic ketoacidosis, take it from me. They can present with a severe upper abdominal pain, vomiting. So they come like gastritis to you, but actually, if you see non-diabetic, you do urinary acetone, it will be very positive. Under sugar, it will be 600, 700. So this is very typical of diabetic ketoacidosis. Next patient with a basal pneumonia can present with epigastric pain. Third, I'm sure all of you might know this time, inferior wall ischemia or inferior wall infarction. They can present with the epigastric pain. So epigastric pain doesn't always mean there's an abdominal problem. It could be entirely a medical problem. Even people with a porphyria, it can present with abdominal pain. So it is a totally a biochemical problem. So you need to keep an open mind. Not everybody walking through the door in the department of surgery doesn't mean they need my presence and also my knife. So you need to have a broad-based approach to all these common acute abdominal conditions. Let us go one by one. First pattern, okay? See here, what you see here, a shock. When I say shock, a patient presenting to the emergency department with a severe acute abdominal pain with a hemodynamic instability. That is what I mean. What do you mean by hemodynamic instability? They have hypotension, tachycardia. Okay, it may be because of hemorrhagic shock, bleeding inside, internal bleeding, like what you see in this picture, rupture ectopic, or could be ruptured abdominal aortic aneurysm, or GI bleeding like peptic ulcer bleeding, or it could be a hypovolemic shock, may not be a bleeding inside, that is fluid loss, where all you can lose fluid. I already told you several times, pancreatitis is 30% retroperitoneal burn. You have to imagine it is a patient with the burns, retroperitoneum is burnt, 30% of your fluid, body fluid lost. Or mesenteric infarct or ischemia, a lot of fluid, even blood could be lost. So these are the common cause for patient presenting with severe acute abdominal pain with hypotension. So this is what the clinical pattern. So GI bleeding or leaking aortic aneurysm. Again, never forget. The next pattern, invariably you will be seeing every other day when you are posted as a CRRA, is a patient presenting because of a hole in the bowel, maybe spontaneous like perforated duodenal ulcer, or traumatic because of some injury, stab injury, bullet injury, or bull-gore injury, like that. So it causes what? Injury to the bowel, like small bowel, large bowel, or stomach. So germs get into the peritoneal cavity, causes chemical to start with, later to the bacterial peritonitis. So the patient will present to you with a board-like rigidity. Patient will be lying still. So this is a classical feature of general peritonitis, like a patient presenting with a small hole in the bowel like that, with a spillage of all the content from inside. Depending upon the thing, even if it is a large bowel, patient will have fecal peritonitis, very, very serious problem. So whenever there is a perforated peritonitis, there are 5 classical characteristic features. First, sudden onset of pain. 2 o'clock, he was all right. 2:05, he has a severe pain, intolerable pain. So sudden, like a lightning strikes, sudden onset. Second, the pain is so severe, sustained. In other words, it never goes away. It is not waxing and waning of pain, like intestinal obstruction. See, pain comes in waves. That is intestinal obstruction. Here, pain comes and stays all along. You imagine, you pray God, when I'm going to get rid of the pain. You beg the doctor to give you some narcotic analgesics. That is a severe, sustained pain with a visual analog score of 9 or 10 even. And the patient will be lying in the bed like a statue, because every little movement will hurt. You ask the patient, how did you manage to come from your place? He might be coming, for example, I'm in Erode, patient may be coming from Karur, which is about 60 kilometers. You know, the road from there to here has 63 bumpy rides, like small areas where the car goes. So every speed breaker, he'll be able to remember because it hurts. So many speed breakers, every movement hurts. So that's a classical description. You have to ask them when you are traveling in the ambulance, how was the trip? So it is a terrible travel. Every time when he goes through the speed breaker, I was feeling the pain, sir. Diagnosis, peritonitis. Very simple. So the patient is lying still. Second, you just examine the patient's abdomen. It feels like a board, because our abdominal wall is like yielding. Okay, yielding or elastic, but when it becomes, the muscle goes for a spasm, okay, voluntary contraction or involuntary contraction at a later, then it goes for a stone-like. That's why I made it board-like or just mnemonic stone-like abdomen. And then you put a stethoscope, because the peritonitis makes the whole abdomen or the gut, small bowel, large intestine to go for ileus. So they go on a strike. Nobody moves. The bowel movement is absent. So you just Even you will not hear even a single vowel sound. So it is a silence, absolute silence. Okay, this is very, very important thing. Okay, so it is as if you are just in the prayer room. Everybody is so silent. That's what, if you carefully listen in the abdomen, you can hear only the heart sounds of the patient because nothing is happening in the abdomen. So that is a classical features of hole in the abdomen. So this is a very such case of acute abdomen because of the perforated duodenal ulcer. See, for example, here the patient is having a perforation like here, and I'm suturing, but you can see here there is a, as you can see, I'll just go back one more time just to give you an idea. Meniscus sign. You see the right dome of diaphragm, left dome of diaphragm. What you see underneath the right dome of diaphragm is normally, this is the white color is the liver. Between the liver and the right dome, there is a small sliver of air. This you should not mistake it as an air here. This is very typical. Okay, meniscus. We always say third day, fourth day after your dark moon, that is Amavasya, we call this one. Okay, this is a meniscus, typical meniscus sign. Whereas here, the gastric shadow or colonic air shadow will give you a different picture. It is not a very typical picture of this. Okay, this small amount of meniscus sign perfectly present only on the right hemidiaphragm, especially in X-ray of the chest. It is seldom seen in the X-ray of the abdomen. Take it from me. Is a classical sign of perforated DU. You need to do a laparoscopy or laparotomy and suture this hole. Okay. Third, of course, is the one, the chapter of today, that is appendicitis. So acute appendicitis or acute cholecystitis, depending upon where the inflamed organ, appendicitis, appendix is present in the right iliac fossa. So there is a guarding and tenderness there if you put a hand. So localized tenderness according to the site of inflammation. If there is a Murphy's sign in cholecystitis, McBurney's sign in appendicitis, diverticulitis, there is a tenderness in the left iliac fossa, like that. Okay, appendicitis should be very easy to diagnose. Even we say, even orthopedic surgeon or a dentist can make a diagnosis, but it's not always so. There are some challenging situations. We'll come to that in a minute. And the next important pattern you need to understand is intestinal obstruction. Okay, what is meant by this? Imagine you have ileocecal tuberculosis. Okay, so when there is a blockage in the bowel, and then what will happen? Proximal bowel, all this proximal bowel dilates because the traffic is obstructed because of the stricture of the ileocecal junction. So all this effluent in the small bowel contents, they all stays there and causes hyperperistalsis. So central abdominal pain. Being small bowel is a mid-gut, they have a central abdominal pain. And it is comes in waves. That is a very important. They are not continuous pain. They are actually colicky, intermittent pain, or pain coming in waves, or you can say coming and going, waxing and waning pains. So that is a classical description of intestinal obstruction. And what will happen after some distance, and the whole thing patient throws. First, the gastric content, that is the bilious. Then small bowel content, that is feculent. Then, so patient very classical evidence. So initially they say small amount of food they ate, then the bile comes, then so in other words, duodenal content, then jejunal content, then even the ileal content will come. If you don't treat him by IV fluids, patient may even go into severe dehydration, okay, hypovolemic shock. So vomiting is a very important cardinal symptom. The third, of course, is because of the distance of the most of the bowel, small bowel, the whole abdomen looks like a 9 months old pregnant lady. So distance, and nothing goes beyond. Okay, no traffic in the large intestine. So obviously the patient will not pass any flatus. Patient will go for absolute constipation. So abdominal pain or colicky abdominal pain, vomiting, distension, constipation are the 4 cardinal symptoms of intestinal obstruction. Very, very important you memorize this 4. Repeatedly asked. And if you see an X-ray, whenever obstruction of bowel is considered as a differential diagnosis, you have to have 2 views of X-ray of the abdomen. I'll repeat, for peritonitis, you do X-ray of the chest to see gas under the diaphragm. Whereas for intestinal obstruction, we do X-ray of the abdomen, erect and supine. And so for any acute abdomen, you do all the three X-rays: X-ray chest erect, X-ray abdomen erect, X-ray abdomen supine. Because supine abdomen, if you see, all the dilated loops of bowel, gas-filled, centrally occupying, it will be seen like this. And when you ask a patient to sit or stand and take a picture, multiple fluid levels will be seen. Any fluid level, more than 2 fluid level is abnormal. You should all take it from me. 2 fluid level only accepted. If they are more like 9, 10, 11, then it is more distal obstruction. If there are 4 fluid level, where is obstruction, sir? Jejunum. If there are 8, where is obstruction, sir? It is terminal ileum. As simple as that. So you should know the level of number of fluid levels are important to know the approximately the site of obstruction. Is it proximal or distal part of the bowel? Okay. And CT also very, very important in all cases of acute abdominal pain, because it will clearly show you the dilated, see, valvulae conventives. All the mucosal folds are also nicely seen like a ladder pattern. And the whole dilated fluid-filled loops, gas within the bowel. Okay, all these things you can very easily see. So CT is also very, very important nowadays. Of course, we have to see inside by an operation, either laparoscopy or laparotomy, because the common causes could be an adhesion of the bowel or something within the bowel like a food bolus or a gallstone ileus. Okay, I told you last class or the class before what is the Wriggler's triad. People already read, recollect what is Wriggler's triad. Okay, if you're able to recollect now, add in the biliary tree, small bowel obstruction, and a calcified shadow or a gallstone down in the ileocecal region is a gallstone ileus. Okay, because of cholecystoduodenal fistula. Very, very important. If you know all these factors I just said, that means you're very, very good. You have already passed the exam. The final basket, the fifth basket is the medical illness patient presenting with DKA or pneumonia or like herpes zoster. Okay, what are the laboratory tests minimum we do? We do always all the blood investigation, but other them I'm just mentioning here just for you to give importance to. Otherwise, you will be writing the whole thing. White cell count is very, very important. Okay, if a patient with inflammation of the any part, cholecystitis, appendicitis, they'll have neutrophilic leukocytosis. That's why it is important. Second, serum amylase is important test to do in all acute abdomen. Amylase, acute abdomen, very important. Amylase more than 1000, pancreatitis is confirmed. Okay, next diagnosis. Third, renal function test is important in all cases of acute abdomen, because patient, because of the hypovolemic shock, patient may have increased urea creatinine, one. Second, patient with the chronic renal failure with the increased urea creatinine can indirectly present as a paralytic ileus and acute abdomen. Both are possible. An acute abdomen leads to renal failure, or renal failure patient will present as an acute abdomen, mimic like an acute abdomen. So always renal, and the renal function test is very important. As simple as doing a CT scan. If a creatinine is more than 1.5, don't give IV contrast when we do a CT abdomen. Very important message. Okay, take it up, because it will give you an acute renal failure. Next is a serum albumin. It is a test of a patient's nutritional status. If somebody asks you, tell me one particular test that will tell how nutritious, you're malnourished or not yourself. There are something. One thing very important is albumin, because albumin is produced on the liver. So it indirectly gives you an idea about your nutritional status. And if the albumin is low, that patient is bound to have poor wound healing. or poor anastomotic healing. So albumin should be more than 3 in most of us. If it is less than 3, bad news for the patient. Urine test is important. As simple as pus cells will show it is a case of cystitis, or presence of pregnancy test positivity will confirm the diagnosis of rupture ectopic pregnancy. So urine test sometimes will be clinching the diagnosis even. Ultrasound, we do, all of you know, anybody coming to the emergency room of the hospital at the same night or the next day morning will have the first bedside non-invasive imaging modality next to X-ray, of course, is ultrasound. It will clearly show a tubular non-peristaltic structure, that is appendix, or like a coil, inflamed appendix. Okay, or if it is a gallstone, okay, you can see the liver with the gallbladder with the 2 stones with a post-acoustic darkness, post-acoustic window. Okay, these are all the classical signs. So what we do for acute abdomen, now as a resident, your job is over. Now as a surgeon, what I do, I come and examine the patient, decide, confirm the diagnosis you made, then I make one of these 5 treatment options for the patient. Either I take the patient for surgery same night, like urgent surgery, like perforation, or a strangulated inguinal hernia, or strangulated, bowel because of mesenteric infarct, immediate surgery. Or I do the surgery in the next day or 2, that is appendicitis. Or I do a little later, cholecystitis, all surgical treatment. But sometimes even acute abdominal problem can be managed conservatively for a surgery at a later date. Very important two situations are appendicular mass. We sometimes, if we feel right leg cause a mass, nature is trying to heal it and leave it like that and go back and operate after 6 weeks. That is called Oshner-Sharon regime. We'll come to that in a minute. Acute cholecystitis also sometime we used to treat them after 6 weeks. So that is another way. In other words, immediate surgery or antibiotics, wait, and then when the patient is recovered and willing to undergo surgery, we can always do after an interval. That is called interval appendicectomy. And the final one, of course, is some acute abdominal conditions only need medical treatment. Classical example is acute pancreatitis. You all know, unless patient develops a large pseudocyst or infected collection or pancreatic abscess, medical treatment is the only option for pancreatitis. Okay, you remember the mnemonic pancreatitis, how we manage. You go back and read again. So this concludes the approach to acute abdomen, because only if you have this, the next chapter will be relatively easy and we can move faster. That is, as a surgeon, we are the captain of the ship. There may be a lot of people like you as a resident, nurse there, the sonologist will be there, the radiographer taking an X-ray, but everybody will give you piecemeal information. But nobody stands between you as a surgeon or a doctor and the patient. So you have to take a good history, examine the patient, sensibly investigate, come to a conclusion to manage the patient. That takes years of experience, but I'm sure you will get there. Okay. Now let us move on to the acute appendicitis. I think we'll stop sharing for a minute. Let me try, because I need to interact with you if possible before we go into. Let me see whether if anybody wants to ask, please unmute yourself and come. Let me see whether I can unmute yourself. What is it? Mute all. Ask all to unmute. Okay. You can unmute yourself. Do you have any questions? Otherwise, I go back again in another 2 minutes time. Any of you? Monisha, Gautam, Karthikeyan, Kadiravan. I'm sure this part hasn't been discussed this way by many people I know, but this is in essence the way you need to understand acute abdomen if you want to treat or manage confidently at a later date. That's why the presentation is slightly different. Okay. Anusukita, you want to ask me anything?
Sir, good morning, sir.
Good morning.
Sir, how to
Can you hear
clinically
me?
differentiate
I
between...
can't hear you.
Sir, now can you hear, sir?
Go on.
Sir, clinically, how to differentiate between acute pancreatitis and perforated duodenal ulcers?
Yes, sorry. Can you hear me now? I think I was.
Yes, sir. I'm able to hear you, sir.
Were you able to hear me till now? Because I was speaking without my earphone. I don't know how much you are able to hear. Now you may be able to hear me better now, isn't it?
Yes, sir.
Till now, in the last half an hour, how was my voice? Was it okay to audible? You were able to comprehend?
Yes,
Or was
sir.
it? Okay, fine.
Yes, sir.
Okay. Go on.
Sir, how to clinically differentiate acute appendicitis from perforated duodenal ulcers? Sir?
That's what we are going to discuss in the next 45 minutes. Don't worry, that's the challenge. We'll do that in a minute. Okay, wait for us. Because main chapter, we are just, this is like a opening remarks that itself took some time, but doesn't matter. We are going to the actual chapter now. Okay? Kadiravan.
Okay, sir.
Or Mohana. Okay, let me just mute all current people. Let me just go back to the slides now because already we are sharing the screen again. Acute appendicitis. Right. So let's move on to the acute appendicitis now because this is the very important chapter. What is acute appendicitis? This is inflammation of the appendix present right here at the ileocecal junction. Because it's being a blind pouch, very often you get inflammation of the appendix because of the obstruction to the lumen by what I call a fecalith. It is nothing but a very firm part of fecal matter. If it gets there, the bacterial flora inside, because of any stagnation, that causes inflammation. So fecalith is one of the initiating factor for appendicitis, not always. And appendicitis is very interesting because one, it is one of the commonest cause for acute abdomen. Second, because of its varied presentation. And the varied presentation is mainly one of the reasons is for its varied location. And this picture clearly shows appendix like wagging a tail. Most common site of appendix location is retrocecal. It is hiding behind the cecum. The next common thing is the yellow one, that is a pelvic appendix. The other things like going in front and behind the ileum, pre-ileal and post-ileal. Of course, next is a subcecal. So these are the various, like a clock position you can see. So depending upon that, they can present. And also, it can be a non-obstructive type that is called acute edematous appendicitis. And next is acute obstructive appendicitis. It is just something similar to pancreatitis. We know there are two types, edematous pancreatitis, necrotizing or hemorrhagic pancreatitis. One is a mild variety, another is a severe variety. Similarly, here also when there is a fecalith is obstructing the whole lumen here, the whole appendix is prone for either gangrene or perforation. In other words, acute obstructive appendicitis is prone for more serious problem like perforation and gangrene. Whereas acute edematous appendicitis is like tonsillitis. It can be cured simply by giving them antibiotics. That's why people argue, why don't you treat appendicitis in this COVID era with antibiotics and treat them later with a surgery? Okay. Some people will come with appendicitis symptoms every now and every 6 months, 1 year. That is called recurrent appendicitis. And if you look at the graph, the common age group, it is a disease of young age. In other words, usually around 15 to 25. That is the thing, like school going, college going years. And again, there is a slightly increased incidence in the later age group, like after 60. So before 16, after 60, you can call it roughly. So that is a two peaks. That's the main important thing. It's not like malignancy where only here you have the peak. Malignancy is literally very rare here. So cecal carcinoma of the cecum, more common here. Appendicitis, appendicular mass, more common here. Tuberculosis, more common in the middle age. So that the age group to some extent helps, but we know age group is very, very important only for certain conditions. One of the most important group, you never forget the importance of age, is carcinoma breast. Breast lump diagnosis, age group is very, very important. Next thing is testicular tumor, to some extent it is important. Third important thing is probably the bone tumors, because you know the first decade Ewing sarcoma more common, second decade osteosarcoma more common. Like that, there also the age dictates diagnosis. But here it is just a curiosity. But what is more important thing is the presentation. The three classical symptoms are: patient will say, sir, I had a pain around my umbilicus 2 hours ago. Now I'm having severe pain. Now present all along the right iliac fossa. In other words, colicky central abdominal pain, shifting to the right iliac fossa, and now presenting constantly. That is a classical thing. Pain. One word, shifting pain. Okay. Next is few vomiting. Any inflammatory pathology in our body, appendicitis, cholecystitis, they usually say the food they ate before, they just throw it. It's not like intestinal obstruction where they keep on vomiting. Here, vomiting is only whatever is there remaining, like few vomiters. Okay. And also, if you offer them food, they don't feel like. Child not keen to eat, very important indirect sign of appendicitis. Okay. Anorexia is a very important symptom of acute inflammation in the gut. Third is a low grade fever. So pain, vomiting, fever, if they happen in that order, very, very important. Pain first, vomiting next, fever third. If it comes, that is what we call Murphy's triad. So people will call you, what is Murphy's triad? You should all know. Okay. Next, you have a general examination of the patient. Patient temperature is slightly high. I told you around 37.8 or 38, never more than 38. Tachycardia invariably is one of the signs. Systemic inflammatory response syndrome, SIRS, tachycardia. That if you examine the abdomen, I always write in the exam all acute abdomen or abdominal findings, whether your Hamilton Bailey says or not, you write in your long case, essay writing, inspection, palpation, percussion, auscultation. Most of the findings I have written here are all palpation finding, but inspection you write abdomen mildly distended. I look for any scar, dilated veins. Like that, you just write what you look for at least. Even if you don't know anything about appendicitis, just the way you examine a patient of acute abdomen, if you're able to tell the examiner, if I am an examiner, I'll give you a pass because he has a system approach. He will examine, he'll eventually learn appendicitis. Okay, because I am sure one or a few of you even wouldn't have seen an appendicitis case per se. So it will take some time to comprehend all these signs, but you should get that layout or template done by this time. Okay, what are the findings in palpation? Very important thing is you'll show some classical signs in the palpation. And the final one after palpation, percussion, auscultation is rectal examination. Never forget a rectal examination. Okay, in all abdominal pain. Okay, here there will be a right lateral rectal wall tenderness. But let us go for the important sign, McBurney's point of tenderness. Imagine there is a line between the anterior sphenic spine to the umbilicus, spino-umbilical line. The spino-umbilical line, medial 2/3, lateral 1/3, where you put a finger, your index finger, and press, patient experience pain. That is McBurney's sign or McBurney's point of tenderness. You don't palpate like that. You palpate like this. Okay, that is what McBurney also said. So if anybody asks you in exam, what is McBurney's sign? Immediately you say, don't say Howellian. McBurney's sign is a sign of acute appendicitis, sir. Here there is a tenderness at the McBurney's point, which is nothing but a junction of lateral 1/3 and medial 2/3 in the spino-umbilical line. It is a point of tenderness it raised. Okay, even though the picture here shows a hand, what McBurney himself said, you can see this is the seat of greatest pain. Okay, and it is usually with a pressure with one finger, he said. This great guy. Okay. Next sign, important sign, I am sure you all know by this time, is Rosing sign. You press on the left iliac fossa, patient perceives pain on the right iliac fossa. You press here, curiously enough, patient says, sir, you are pressing there, but I am hurt, getting the pain on the right iliac fossa. This is because nothing but pressure on the left iliac fossa causes shifting of the intestinal loops and causing impinging on the inflamed organ in the right iliac fossa. That's very simple to comprehend. So Rosing sign. Then Soya sign is a third less common sign, but this is very, very typical. If patient is, because most of the appendix I told you already are retrocecal appendix, isn't it? Retrocecal means behind the cecum. And if they cause a spasm of the psoas muscle is a very strong flexor of the hip. So the patient usually keeps the hip joint in flexion. In other words, if you ask a patient with acute appendicitis to walk, they walk leaning forward like that. So I always say in Tamil movie that is Adimai Pen MGR, like that, they'll just go like that. Okay, they don't have straight walk. They don't have the military walk straight because of the spasm of the psoas muscle. So if you ask a patient to lie in the position like a left lateral position as drawn here, and if you try to just keep the knee straight and try to hyperextend the hip, patient will have a severe pain because already the patient is not able to straighten. If you bring it this way, because of the psoas spasm, they'll have severe pain. That is called psoas sign. It is not a classical sign of appendicitis alone. You should take it from me. There are other causes for psoas sign. One is a psoas abscess due to ileocecal tuberculosis, or any patient with a retroperitoneal bleed due to ruptured iliac vessel. Okay, they'll have a psoas spasm. Okay. Last sign you should remember is a Cope's obturator sign. What is obturator sign? The pelvic appendicitis. Patient may have hanging pelvis, a pelvic appendix like this, and causes the inflammation around the obturator internus muscle. So because of that, whenever you are trying to do this, that is you keep this knee joint at right angle like this, and you try to do an internal rotation of the hip by just bringing the ankle outwards like this. If you do this way, you can see it rotates inside. The internal rotation of the hip causes a severe pain for the patient that is called a Jaggery-Cope's obturator sign. So these are all the various signs you should realize it. And the Blumberg sign is that last sign. It is non-specific, present in all cases of localized appendicitis or a cholecystitis or even a diverticulitis, wherein this is otherwise called release sign or rebound tenderness. What is release sign or rebound tenderness? That is, you just talk to the patient and keep a hand on the patient's abdomen, like where it hurts, like a left iliac fossa in a case of diverticulitis. When the patient is least expecting it, you suddenly release the hand without the knowledge of the patient. Then look at the patient's face. Patient winces with pain. Patient need not say, sir, that hurts. The patient face will tell, oh, like that, that suddenly go. So this is the way you have to describe. Sir, I'll elicit Blumberg sign by keeping the hand on the inflamed area, that is, and I'll continue to talk to the patient. When the patient is least expecting it from me, without the patient's knowledge, I suddenly take the hand off the abdominal wall. During that sudden spring back of my hand, and patient has a pain that can be seen by witnessing the patient's face, not asking the patient. Patient need not talk to you or say anything. So that is a thing. Face says everything. Okay, this is a sign of peritonitis. Very important thing. You should keep practicing the way it is elicited, the way you should express it to the examiner. Okay. What test we do? Hematological, neutrophilic leukocytosis, biochemical, because there are humpty number of differential diagnoses. Because Anusukita just now asked me, so we need to tell there are at least 20 to 25 differential diagnoses for appendicitis. Okay, we need to go by one in a minute. All other tests are important because appendicitis, pancreatitis is a different diagnosis also. So we always do these three investigation in all cases of acute abdomen. Take it from me. In the X-ray, if you're lucky day, you'll be able to see what I call a calcified fecolith, that is called appendicolith. Appendicolith is nothing but fecal matter with a little calcium seen. Yeah, this is the cecum, this is the appendix. Okay. Next, of course, as already I told you, you will see a aperistaltic, blind ending, enlarged appendix in the behind the cecum. Okay, like this. Or in the other view, it will be seen like a coin. And also in the CT, you will be able to clearly see appendix and also periappendicular inflammation. Okay, that is called a phlegmon. Phlegmon is a very important terminology in CT abdomen. So you have to say appendicular phlegmon or periappendicular inflammation, pelvic abscess, all additional features are seen in CT abdomen. Coming to the differential diagnosis. If you have a 5-year-old boy presenting with appendicitis, there are at least 6 differential diagnoses you have to entertain. If it is an adult like you and me, you may have to consider these things as a differential diagnosis. If it is a lady, usually the reproductive age group, there are additional differential diagnoses one may have to consider. And if it is a 70 or 80-year-old man, there are rare pathologies that can mimic like appendicitis. In other words, there are humpty number of differential diagnoses. So you write less on appendicitis, more on differential diagnosis. That is the challenge for all of you. Because if you know appendicitis, you know the whole acute abdomen. Because so many differential diagnoses. That's why we say you have to understand appendicitis so well. Let me just give you a little touch because it is too early for you to understand all the differential diagnosis in a single day. But at least I'll tell you a glimpse. Say, for example, you have a 5-year-old boy admitted with acute appendicitis. What are the differential diagnoses they can have? It could be an amoebic or infective gastroenteritis because he had something to eat the previous day, like a pizza or burger in a restaurant. He'll come with pain in the right iliac fossa. Normally, when you have amoebiasis, what do you have? Diarrhea. So whenever diarrhea is a very unusual symptom in appendicitis, okay, you should take it from me. So it is common symptom in infective enterocolitis. Next condition, mesenteric adenitis. What is mesenteric adenitis? Beware, you have a 10-year-old girl presenting with sore throat and you swallow that saliva with the inflamed tonsils and all the viral particles from the sore throat will enter the intestines. From there, it will go into the mesenteric lymph nodes. So that will give you some pain. So this is the classical history. They'll have a brief history of cough, sore throat, followed by cervical lymphadenitis and the central abdominal pain. Okay, and they'll have one more important sign that is called shifting tenderness. Okay, you just take a note down. Media's mesenteric adenitis, classical presentation in the examination finding is it is not shifting pain, shifting tenderness. Why is shifting tenderness? You examine the patient on supine, they'll have pain in the center abdomen, for example. You ask a patient to lie on the sides because mesentery shifts. Okay, mesentery is not a fixed organ. Small bowel mesentery, it shifts to the side where you turn. Right side means this side it shifts, left side means it shifts. So the tenderness also to some extent will be shifting. That's why it's called shifting tenderness. But the third and fourth are very important for you. That is intersusception and Meckel's diverticulum. Okay, and enoxaline purpura in a case where is the season is for dengue hemorrhagic fever, it may also mimic like appendicitis. Rarely, even a lobar pneumonia patient can or a child can present with an appendicitis. But pneumonia, take it from me, usually they have a very high fever. In addition to tachycardia, because it is a pneumonia with a patch in the lung, they have a tachypnea. Respiratory rate is very high with the ala of the nose. You can see the nose breathing, hyperventilation. Okay. Coming to the two important things you never forget in a child. Meckel's diverticulum. What is Meckel's diverticulum? Remember, it is a true diverticulum. What is true diverticulum? A diverticulum which is having all the layers of the intestine. Mucosa, submucosa, muscularis propria, and serosa. Pseudodiverticulum, it only has mucosa and serosa at the maximum. Classical example for pseudodiverticula, sigmoid pseudodiverticula, or periampullary diverticula, or pharyngeal diverticula like Zenker's diverticulosis. True diverticulum, Meckel's diverticulum is a very, very important thing you should realize. Okay. And rule of two, all of you know, it is usually present 2 feet away from the ileocecal junction, normally about 2 inches in length, present in 2% of the individual. Okay. And rarely, in other words, 2% of the people can have ectopic gastric mucosa, creating a peptic ulcer in the Meckel's diverticulum, presenting as a GI bleeding. That is a rare thing. But the Meckel's diverticulum is very common in children. 2% is quite a significant number. Next important thing, all of you to important differential diagnosis in a children is intersusception. What is intersusception? If anybody asks you, simply you tell like this. You just give a signal. Telescoping, sir. Telescoping of the bowel. That is a proximal bowel. That is ileum. Okay, going into the large intestine, into the cecum. So ileocecal intersusception. Okay, it is, in other words, ileum, because of the enlarged Peyer's patches. Okay, it considers the Peyer's patches as the food. So it tries to push the food. So that peristalsis takes the whole this intestine, prolapsing into the ileocecal valve, into this large intestine. That is called ileocecal intersusception. And when we read intersusception, we'll read what is intersusception, intersusceptum, intersusception. There are a lot of terms that will be confusing to you now. All you need to know is telescoping of the bowel, which is common in the first 2 years of your life. That is 2-year-old child presenting with brief viral illness because of enlarged Peyer's patches. It causes ileum prolapsing into the cecum as a ileocolic intersusception. Okay, coming to the adult like yourself, the common differential diagnosis, if at all, is first 3: ureteric colic, perforated duodenal ulcer, pancreatitis. Ureteric colic, because if you have a right ureteric colic, loin to groin pain, sometimes it will present with a stone in the vesico-ureteric junction on the right side, will mimic like appendicitis. But the additional feature of testing the urine for red cells or X-ray showing a stone along the ureter will reach the diagnosis. So it's not that difficult nowadays. Perforated duodenal ulcer can also present like this because patient will present with the pain in the upper abdomen, but because of the fluid tracking on the right paracolic gutter, they may have sometimes predominantly findings in the right iliac fossa. Sometimes it will confuse you. Okay. Pancreatitis also can mimic like an appendicitis, but serum amylase, if it is raised above 1000, it is pancreatitis unless proved otherwise. Crohn's disease is a differential diagnosis for appendicitis in abroad, because there appendicitis in a young adult here in India is the way a Crohn's disease in a young adult present in abroad. Okay, UTI also can present like this. So this is a classical the way a stone in the ureter. Okay, they'll present with this type of unilateral loin to groin pain. Okay. What about the lady with in the reproductive age group? They can present with mid-cycle pain, okay, because of ovulation pain, torsion of ovarian cyst, infected tubes like salpingitis, rupture ectopic or endometriosis. So anything you know about the how to remember all these things? Remember the female organ, ovary, tube, uterus. So ovarian pathology, that is the ovulation pain, or the next is torsion ovarian cyst, tube, salpingitis, ectopic, uterus, endometriosis. So like that, very easy to remember if you know. And then most of them, if you take a good history of their menstrual history, you will be able to make a diagnosis. Here is a very typical torsion of the ovarian cyst. Here ectopic pregnancy, swollen the tube. You can see with all the contents of the conception is all extruded with the blood in the pouch of Douglas. Okay, that's all you can easily see. What about elderly people? If a 70-year-old man can't he have an appendicitis? Yes, but rare. More common in those people are diverticulitis, because sigmoid colon, even though it is present in the left colon, left side, sometimes if the sigmoid loop is so long, it can also present with the tenderness in the right iliac fossa. Of course, CA, CCAM, intestinal obstruction with the gangrene or a small bowel ischemia can mimic like an appendicitis rarely. So all these things you keep in mind. Let us go on to the management. Any patient with appendicitis, the management is AAA. Remember, as soon as patient comes, you finished examining the patient, making a diagnosis, you give them analgesia. Because patient is having pain, don't wait for the surgeon to come. Analgesia is your jurisdiction. Next, it is an infective problem. You know that because it is a acute appendicitis is a septic focus. So source control, antibiotics you have to give IV because the patient cannot absorb orally. Third, source control. You have to remove the offending organ. If it is a perforation, close the perforation. If it is an inflamed organ, remove the organ. Especially if it is a gallbladder, cholecystectomy. Appendicitis, appendicectomy, like that. Okay. How do you do surgery? You can do open surgery or laparoscopic surgery. That is rarely we do also endoscopically, but these two are important. You should know. These are the various incisions we make. Okay, the commonest incision is drawn here for you as undergraduate. You should know the classical gridiron incision. What is gridiron? Gridiron is like this. If anybody asks you like that, gridiron is crisscross. That is, you make the incision in the skin this way, okay, and divide the muscles other way, peritoneum this way, like that. Each layer is, exposed in a different directions so that there is no weakening of the wound. So the wound is less weakened because skin incision, muscle division, peritoneal incisions, all in a various planes like this. Okay, if you know that, that's good. So the wound weakening is less in a classical gridiron incision. But what is the minus on this wound? Because it is not cosmetically acceptable incision. If you make any incision like this, exactly at the McBurney's point is not good. A cosmetic incision or an accepted incision is like a transverse incision in the lower abdomen, which will be hidden by the patient when they are wearing the underpants. That is called a lance incision. So lance incision is what we do nowadays. This is what normally we used to do those days. Again, there are other incisions also we use. Bartels incision, right paramedial incision, lower midline incision. So in other words, 5 different surgeons, they use 5 different incisions. Laparoscopically, we do appendicectomy commonly nowadays. Rarely, we tend to do a procedure that is called nodes appendicectomy. Okay, what is nodes appendicectomy? Natural orifice transluminal endoscopic surgery. Okay, so you just expand what is nodes, and it is all done with a flexible endoscopy going through the mouth. If you know that, well and good. People interested, go and read what is nodes appendicectomy in the net. This is what you should know as an undergraduate. A gridiron or a lance incision is made under patient under spinal anesthesia. We divide the external oblique aponeurosis. Then we split the transverse abdominis and internal oblique muscle. Then we divide the peritoneum to expose the appendix. The appendix is identified by the convergence of the 3 tinea coli. Okay, these are all the tinea coli, 3, they converge here. And there you just see the appendix. And this is the mesoappendix, which is having the blood supply. You divide the appendicular vessel, then appendix is ligated at the base and then divided, and the remaining the base of the appendix is buried inside by taking what we call the old lady's purse, like a purse string suture, doing a purse string suture. Then you push this appendicular stump inside and close it. So the appendix is buried once for all, the stump, and you send this particular specimen for histopathological examination. Then clean the whole peritoneal cavity free of infection. That same thing you can achieve by laparoscopy, by standing on the patient's one side, that is on the left side, making 1, 2, 3 ports. Okay, sometimes we put here also, but this is the common things. Put, then enter. So 3 ports you put, look at the appendix and remove all the blood vessels, and then put a suture at the base of the appendix that is called Erode knot. This is the only important word you should understand in laparoscopic appendicitis. Like one word for laparoscopic cholecystectomy is Callet's triangle. Sir, I will expose, dissect the Callet's triangle, then ligate the cystic duct and artery, lap chole over. Like that appendicectomy, sir, I will expose the appendix by following the tinea coli, then appendicular vessels ligated. The base of the appendix is ligated by using a Erode knot. If you go use that, that is a surgeon's terminology. Then the surgeon will know, yes, this particular resident or CRRA, he knows what he is talking. So this is what this small video clip will show. We are going through the optical port inside the abdominal or peritoneal cavity. This is the mesoappendix. We just, with the help of the energy source diathermy, we just pulverize under the hemostasis achieved. Appendix is held, and we put something like a knot that is called Erode knot. Okay, like a hanger's knot, and we put 2 and cut in the middle and remove the appendix like this. Okay, so this is what we normally do, and we take it out. Sometimes I told you already, appendicular patient will not come on the same day when they have the pain. They come 1 week, 10 days, even 6 weeks later. So that time, when you see the nature itself trying to protect it, the inflamed appendix will be covered by the cecum, the small bowel and omentum, and they feel like a mass. If you go and examine the patient, you will not have McBurney sign. You will have right iliac fossa mass. So this is a very important differential diagnosis for right iliac fossa mass, where the 5 important causes for right iliac fossa, take it from me. Whenever you feel a mass in the right iliac fossa in a patient presenting with 2 or 3 weeks of abdominal pain, commonest is appendicular mass, ileocecal tuberculosis, cecal tumor, Crohn's disease, lymphoma, rarely amoebic typhlitis or actinomycosis. Okay, if you want to have 7, but 5 is good enough for you as an undergraduate. And if you do that, you do an ultrasound or CT, and then the differential diagnosis of right iliac fossa mass, just now I mentioned to you, write it there. Then you tell appendicular mass is nature's way of trying to localize the infection. You don't go and unravel trying to remove the appendix in a difficult. In other words, it is nicely protected by the nature, the cecum, omentum, and the bowel. You have to just remove them all, then take it. It is a very challenging surgery. So that's why we normally follow a procedure called a conservative, non-operative regime, that is called the Ochsner-Sharon regime. Spelling is very important for all of you. Take down, where you admit the patient, you put a Ryle's tube and aspirate, give analgesia, give antibiotics, you actively monitor the patient's pulse, pain, and everything. And if the patient shows signs of improvement, pulse rates coming down, temperature settling, patient feels hungry, he is getting better, the mass size smaller, getting smaller every day, that is a successful regime. Then you continue, bring the patient after 6 weeks for a surgery that is called interval appendicectomy. So that is what appendicular mass. Okay, what about the other common complication of appendicitis, that is called appendicular abscess? It is like pancreatic abscess. Whenever the word abscess means pus inside, it is pus in the region of right iliac fossa. Pus anywhere in our body will be very painful. Even a small drop of pus underneath your nail bed, how painful it is, you remember that. Second, pus anywhere will give you germs entering the stream, bloodstream, like a septicemia. So patient will have swinging temperature. Okay, so patient will have temperature chart. If you see, they'll have 39 one day, go down 37 next day, like that. Swinging temperature, only few conditions: urinary tract infection, cholangitis, acute appendicitis with appendicular abscess, subdiaphragmatic abscess, or malaria. See, UTI. So like that, you have to have some conditions where the temperature goes so high. Okay, uncomplicated appendicitis, low grade temperature. Complicated appendicitis like an abscess, high swinging temperature. And if you examine the abdomen, patient will not let you examine because it's so tender. And there you do a CT scan and you go for a laparoscopy or open operation, or even sometimes radiologists can also do a guided drainage where you see a pus. So pus anywhere in your body, the only word important is drain the pus, keep a drainage tube. So pus, what will you do? If anybody asks you, don't just think what I should say. I have to drain the pus, sir. Then I will leave a drain, sir. Why drain? Because patient will continue to discharge pus for the next few days. So leave a drain until the drainage amount is less than 25 ml. Then you remove the drain. It may take 5 days, 10 days. Till that time, you have to leave the patient with a drain. If you don't treat appendicitis, can appendicitis kill a patient? If somebody asks you, yes, sir. If appendicitis is a fecal peritonitis, it can cause septicemia, shock, it can kill a patient. Sometimes it can go on with the lingering infection for many, many months with the intra-abdominal collection, even a pelvic abscess like this. So it is a serious life-threatening problem. That's why patients are worried. If you say appendicitis, one of your patients, they'll come immediately rushing to you. If you tell even a rare conditions, like you have a aneurysm of your cerebral artery, they are not bothered, okay, because they are not aware of this. Appendicitis is one like COVID infection. They are so worried, they'll come to you next minute, okay. So that comes to the end of the day. We have, as I promised to you, we are able to finish in time. We have 5 minutes to discuss. Let us unmute you all and let us interact. Now, if you have any questions on appendicitis or acute abdomen, you can do that. You can unmute yourself now. I allow ask all themselves. Yes, Karthikeyan. Who else wants to ask? Pradeep will ask some.
Sir, good morning, sir.
Bharat, yes, Bharat. Good morning.
Sir, how severe is the conditions like appendicular rupture, sir? Is it dangerous or can we save the patient?
No. Every patient can be saved. That is, now we are living in an era of modern technology with a very high-end antibiotics, good intensive care, treatment facilities, and also very excellent surgical expertise. So the mortality, patient dying of appendicitis is now getting less and less common. But still, having said that, appendicitis can lead into fecal peritonitis. So if a patient is immunocompromised, or if the patient presenting late with the presentation of appendicular abscess later, like 5-10 days, then you may lose a patient. So appendicitis can kill a patient, yes, but it is very rare nowadays. That's all I can tell you. Okay. And any question? Any other questions? Reshma or Satya Gandhi, Diksha Vinod, Nishant, Karshini. Anybody wants to ask question or any feedback? Or let us go back to the 5 quick questions. What, Karshini, shall we go back, go to the MCQ? What do you think? Can we go straight to MCQ, or you think there are somebody in the chat box? Let me see anybody in the chat box. Anybody has written? I don't see any questions today. Let's go to the question. I mean, I'll just quickly go to the discussion. I think all of you can unmute yourself, whoever wants to give an answer. Air under diaphragm is present in following conditions except. I've given you 5 conditions. One of the conditions, there won't be any gas or air under the diaphragm. Which condition is that? A, B, C, D, or E? Anybody? Bharat, you want to address this question? This is perforated appendicitis, duodenal ulcer, small bowel enteric perforation, diverticular perforation, all are viscous. That is where there is a gas already there. So they all will have gas at the diaphragm. Whereas gallbladder normally, when it is perforated, it only causes biliary peritonitis, no gas at the diaphragm. Okay, C is the response you should have chosen, just for your information. Okay, next one. Most accurate imaging modality for appendicitis. I have given you 5 examples here. Let us ask Ajay now. Ajay, you want to take this challenge? Which one you will do if you are given money, time to send the patient, or which investigation is very accurate in clinching the diagnosis as far as the imaging modality is concerned? Anybody else wants to give an answer for this simple question? Yes. I hope this is not that difficult. Kadiravan, come on, tell something. A, B, C, D, E. Pick some alphabet. Can't you mute, unmute, or is there any problem of unmuting? I don't know. Let us see. Participants. Ask all to unmute. Okay. Just, yes, Ajay. Now you are able to do. Yes, Ajay.
X-ray abdomen supine, sir.
X-ray abdomen supine is the most accurate imaging modality for appendicitis. That's what you're telling. Why you said that? Why you chose that? You
So no, the cost effective.
No, there is no. What is the question there? It is not cost effective. What is the? You read it carefully.
The most accurate imaging modality for appendicitis, sir.
The most accurate term is otherwise called, which is the most sensitive and most specific investigation. If you do that test, you will never miss a diagnosis. That is what this is all about. Which one will not miss a diagnosis?
The CT abdomen is fantastic, sir.
Yes, because even ultrasound, we may miss the diagnosis in 10% of the people. See, out of the investigation here, CT is the best investigation. Okay, because
Yes,
PET CT is better than CT. Don't go for PET CT. PET CT may be okay for cancer patients, not for appendicitis. Okay, so that's the thing. So in other words, each one, the question is more important than the responses you are about to choose. First, read and understand the question, or then you choose your response. Okay. Next, let's go on to the next one. What do you see in this abdomen? CT abdomen. Now the CT abdomen, you say, this is, you are seeing the CT by standing on the patient's foot end. So this is the right side, that is the left side. What you see here is a psoas muscle. And in front of the psoas is what you see here. What is seen here is white, is as white as a bone or lith. Like a stone or bone will be white in color. You take it from me. The CT, stone and bone are white in color, or something filled with a contrast. Like we give IV contrast, that also will be white in color. For example, there are a few things white in color also. So 3 white things in the X-ray, CT, or these are things. Any blood vessels, or any calcified shadow, or any bony shadow will be white in color. What is black in color? All air will be black in color. What is gray in color? Anything with a fluid filled will be gray in color. So it's just an idea about the Hounds, that is all called Hounsfield unit. Okay, this is actually appendicolith, a calcified fecalith in the appendicular region, one of the indirect sign. Commonest site of appendix, Kadiravan will ask. Kadiravan, you can see his name in front of my Zoom. Pick something. Kadiravan, unmute yourself. I want to hear from you. Okay, Karthikeyan, try. Okay, this is, I told you the first slide itself, it is more than 60% is actually retrocecal. Inguinal hernia with appendix as a content is called what? See, there is an inguinal hernia chapter is over already. If you have appendix as one of the content, that is given a different name out of these 5 different eponyms for hernia. Anybody here, price exam going students, please try. Is Amion's hernia. Okay, Amion's hernia is the thing because Claudius Amion is actually the person who also did the first open appendicectomy. And also Amion's hernia is the hernia with appendix there. Okay. And the next important thing is the first laparoscopic appendicectomy is done actually by another German. He is called as Professor SEM, SEMM. Okay, he is actually one of the obstetrician, gynecologist, okay, 1980s. He described a laparoscopic appendicectomy first. These are all MCQ questions at a later date. Okay, students, I think we'll call it a day now. I think we have finished successfully the module 13. Let us move on to module 14, which to me is equally important because all acute abdomen is very, very difficult to understand if you read on your own. Okay, you will be thrown into a dark. So I'll take you through acute abdomen for 3 more sessions. Number 14, 15, probably 16 also to some extent. So next is a small bowel obstruction, strangulated small bowel, how to approach in a patient who is having a colicky abdominal pain. Okay, same time next week. Until the time, goodbye all of you. Thank you very much. Have a relaxing weekend. Bye-bye.